Hey everyone, and welcome. Let's just jump right in with a scenario. Imagine a patient gets rolled into your unit, burns over 40% of their body. The next few minutes, well, they could literally determine if that patient survives. So today, we are going deep, and I mean deep, into the essential skills of burn management. So here's how we're going to break it all down. First, we'll talk about those initial, absolutely critical actions. Then, we're going to get into the nitty-gritty of mastering fluid resuscitation. After that, we'll cover what you need to be monitoring and what complications to watch out for. We'll also touch on minor burns and a couple of really serious conditions that can actually look a lot like burns. And then to wrap it all up, we'll do a quick quiz to make sure all this vital info really sticks. Okay, let's start at the very beginning, that first minute. When you're dealing with a severe burn, what you do in those initial 60 seconds can truly set the stage for the patient's entire recovery. This is where you can make a massive impact. Okay, picture this. The ambulance doors fly open. Your patient is here. They've got a severe thermal burn. They are in agony. You can see the fear in their eyes. The whole team is looking at you. What is your first move? This is that moment, right? Everything that comes next hinges on this. So here they are, the three absolute, non-negotiable first steps. Priority number 1, stop the burning process. I know it sounds obvious, right? But if their clothing is still smoldering, or there's a chemical still on their skin, the damage is actively getting worse. Right after that, you apply cool water. And notice I said cool, not ice. Ice can actually cause more tissue damage. And then we go right back to the fundamentals, your ABCs. Is the airway open? Are they breathing effectively? Is circulation adequate? This is the foundation of all burn care. So, once you've tackled those immediate life threats, we're moving on to the next critical phase, fluid resuscitation. This, right here, is where the real science of burn care kicks in, and trust me, getting this right is a matter of life and death. So, why the huge rush to get fluids in? Well, think of your circulatory system like a big plumbing network. A major burn basically pokes a ton of tiny holes in all the pipes. Fluid starts leaking out of the bloodstream and pours into the surrounding tissues, which is what causes that massive swelling. We call that third spacing. This leakiness leads to a huge drop in blood volume, and that puts the patient on a fast track to hypovolemic shock. So our job is to refill that tank, and we have to do it fast and we have to do it smart. So how do we do it smart? We use an incredible tool called the Parkland formula. If you are planning on working in any kind of critical care, you absolutely have to know this inside and out. It is the gold standard for figuring out exactly how much fluid our patient needs up front. And here's the formula itself. It's 4 milliliters of Ringer's lactate times the percentage of total body surface area that's burned times the patient's weight in kilograms. Now, this formula is a fantastic starting point, but you've got to remember it's a guide, not a rigid rule. You'll likely have to adjust it, especially for patients with, say, inhalation injuries or for those who are obese, because their fluid needs can be even higher. Now, just calculating the total volume is only half the puzzle. The timing of how you give it is just as important. You give the first half of that total volume in the first 8 hours from the time of the burn. And that is such a key point. It's from the time of the injury, not when they get to the hospital. The second half is then given over the next 16 hours. This whole front-loading approach is what we need to do to get ahead of the shock. Okay, so you've got the IVs going, the fluids are running at the right rate. Your job is far from over. In fact, it's just shifted. Now you switch from intervening to being a hawk-eyed monitor. Your assessment skills are everything right now, as you watch for signs that the resuscitation is working and for any potential complications. So, how do we actually know if all that fluid we're pumping in is doing its job? Simple. We look at the kidneys. Urine output is the single best, most reliable indicator we have for adequate organ perfusion. It's like having a little window that lets us see what's happening inside the patient's body. But of course, it's not just urine output. You're doing a full head-to-toe assessment. You're checking their level of consciousness. Is their brain getting enough blood? You're watching their blood pressure and heart rate to make sure they're hemodynamically stable. You're listening for bowel sounds because you're on the lookout for an ileus, which is when the intestines just temporarily shut down because they aren't getting enough perfusion. And you're keeping a close eye on labs like hematocrit and hemoglobin for fluid status and arterial blood gases to check for metabolic acidosis. And here's one of the great ironies of burn care. The very fluids that are saving your patient's life can also create a brand new life-threatening problem, massive edema. For patients who have burns on their face, neck, or chest, this swelling can squeeze their airway shut with terrifying speed. You have to be ready for a prophylactic intubation if you see any signs of respiratory distress, like a hoarse voice or if they have trouble swallowing. So, up until now, we've really been zeroed in on major, life-threatening burns. But you're also going to see a ton of minor burns. And, just as important, you need to have two very serious conditions on your radar that can actually pretend to be burns, but they have a totally different cause and a totally different treatment plan. For minor burns, the basics are simple, but they're really important. You absolutely do want to gently clean the area with some soap and water. You do want to use bland ointments like petroleum jelly. And you do want to encourage some gentle range of motion so the area doesn't get stiff. Now, what not to do is just as critical. Never, ever soak a burn in ice water. You can cause even more tissue damage. And don't wrap the wound so tightly that you cut off circulation. All right, now let's talk about these masqueraders. Stevens-Johnson syndrome, or SJS, and toxic epidermal necrolysis, or TEN, are severe, life-threatening skin reactions. They can cause the skin to blister up and peel off in huge sheets, and they can look an awful lot like a severe scald burn. But the cause isn't heat. It's usually a bad reaction to a medication, and recognizing that is step one. This table really breaks down the key differences for you. The main way we tell them apart is by how much of the body's surface area is affected. For SJS, it's less than 10%, but for TEN, it's more than 30%. And here's the crucial part. TEN has a really high mortality rate, around 30%. For both of these, the absolute first step is to identify and stop whatever drug is causing the reaction, and then provide intensive supportive care. A lot like a burn patient, really, focusing on fluids, nutrition, and preventing infection. Whew. All right. We have covered a massive amount of really critical information, so now it's time to see what's really sunk in. We're going to run through a couple of quick clinical scenarios to test your burn care IQ. You ready? Okay, question 1. You're about halfway through your shift. You've been carefully tracking your patient's urine output, and you notice it's dropped below that target of 30 to 50 milliliters per hour. What is your immediate nursing intervention? What do you do right now? The right move is to increase the IV fluid rate, usually by about 10%, and then you reassess. That low urine output is screaming, "I'm dehydrated." It's not a sign of fluid overload. Giving a diuretic here would be a huge mistake. It would just make the patient even more dehydrated. All right, next question. A patient gets admitted from a long-term care facility. They started a new antibiotic about a week ago. Now they've got this diffuse, painful redness all over, and they're starting to shed large sheets of skin. It's affecting more than 30% of their body. What's at the very top of your list of possible diagnoses? If you said toxic epidermal necrolysis, you are spot on. That combination, a new medication plus skin detachment on over 30% of the body, is the classic textbook presentation for TEN. This is a true dermatological emergency. You know, we've covered so much ground today, from that first critical minute all the way to the complexities of TEN. But the skills you've just sharpened, things like fluid management, critical assessment, and differential diagnosis, these aren't just burn care skills. They are the foundation for managing any critically ill patient. So the next time that ambulance comes screaming in, you'll be ready, keep learning, stay curious, because you are going to make a profound difference in your patients' lives.